Listen, if you have gums that are bleeding, then you need to listen up because we're going to talk today all about periodontology, what it is, what are bleeding gums, where it comes from, the bacteria that creates it. This is the podcast, Too Much Plaque to Handle. And my name is Dr. Hannah Price. I am a periodontist. I am a third-year resident. I will be done next June. And we also have Cheyenne here with us, and she is a registered dental hygienist for the past 7 years. And we are going to talk today all about what is periodontology and what exactly my job and her job, how we work together to solve the complex issue of periodontal disease.
Your periodontium supports your teeth. And if you don't have a good foundation, you don't have teeth.
That's fair. So what is your periodontium? Let's go with that. We got your bone. We got the periodontal ligament that goes around each root that actually connects your tooth to the bone. And then we have your soft tissue or your gum tissue. We call it gingiva or mucosa. You have two different types of tissue in your mouth. We have keratinized tissue or keratinized mucosa is what sometimes is described as, or we have non-attached mucosa tissue. Keratinized tissue is a harder tenacious tissue that's surrounding your teeth, and the mucosa is like what's around on your cheeks and in the floor of your mouth. That's a softer mucosa as Cheyenne licks her lips, feeling it. Totally.
I didn't even think about that. As soon as you said it, your lips, I'm like, huh. Like, let me just check mine real quick.
We all do it. You know it's true. I always did that in dental school, trying to figure stuff out. I always use my own mouth.
Yeah. So what does a periodontist specialize in?
So periodontist, I am specializing in the periodontium. So I am a surgical specialist in the dental field. So I'm doing an additional 3 years of a surgical residency where I specialize in maintaining the periodontium, the bone and the soft tissue in your mouth, and making sure that we're maintaining the teeth properly, particularly with patients who have been diagnosed with periodontal disease, who have had a lot of bone loss, a lot of soft tissue loss. There's a lot of disease involved. I also do other types of surgeries with bone graftings, sinus augmentations. We do implants that aren't necessarily perio related, but it does play a huge role because implants are susceptible to periodontal disease. And we get a lot of those cases coming in where they have disease around implants. So I have to know how to handle those cases and treat those patients. I get a lot of referrals from hygienists that they have cases that are very extreme. So typically a patient does not come to see me unless there is a substantial problem. They're coming to see me to actually try to fix what's going on. And so then a hygienist, Cheyenne, if you want to talk about you being a hygienist.
So hygienists specialize in prevention. So you have in dentistry, dentists specialize in restorative. And then each dental specialist has their own. So periodontists doing soft tissue, and orthodontists do braces, oral surgery does all things facial reconstruction. Hygienists specialize in preventative care. So we do your preventative cleanings, which we call prophylaxis, but we also handle periodontal appointments because hygienists specialize within soft tissue prevention. We do specialize in preventing decay, but we actually treat within the soft tissue, whereas dentists treat within the hard tissue. I know I said it earlier, your periodontium is like the foundation of your house. If you have an unsteady foundation, you cannot hold a house on top, so you're going to lose teeth. Within preventative care, hygienists a lot of times see the transition of a patient going from relatively healthy, they tiptoe into gingivitis, the inflammation gets more chronic, widespread if we're having either health issues going on or lack of home care. And so we kind of get to see a lot of times that breakdown from stage to stage. Someone may go from pretty healthy and have a life event happen, and then you see them back and they're now pretty moderate gingivitis, then, if it progresses, we're usually the first ones to see those pockets go from threes to fours to fives to sixes. A lot of times we're the first ones to see separation or pus, the bleeding points, because we're doing periodontal charting at our appointments, and we tend to see our patients as hygienists more than in dentistry in general. We see our patients more than any other healthcare professionals. They're continuously coming back multiple times a year. And within hygiene, a lot of times you only go see the dentist when something's wrong with your hard tissue. So the dentist is not treating the soft tissue, the hygienists are. And then when it becomes beyond what we can treat in general dentistry as hygienists is when we refer to perio. And perio does do non-surgical options as well, but perio really has the surgical side in their wheelhouse to fix and arrest the issues that are at hand so we can get a patient back to having a steady foundation. We can't reverse fully damage that's done always, but we can at least get a patient back to a point of health on reduced periodontium and be able to maintain the teeth that are there.
Yeah, that's a really good point. That once we've hit a certain point, we know that we're going to have to do some more advanced treatment for a patient because it's just outside of the realm of what a hygienist can really treat because they're not able to do full flap debridements like we can because there's a lot of cases that have a very deep probing depths, let's say, just for example, and the severe cases, and the bacteria and the calculus and everything is so far down that we can't just get at it with our hand scalers, and that there's more that goes into it. And I know we'll talk about this in later episodes of like what exactly it is that we do, but we have to think about bone contour. We have to think about excessive tissue. Our goal as a periodontist is to take these aggressive cases and stabilize them so that they are maintainable at home, because that is the number one key to stabilizing a perio patient is getting them maintainable at home. If they have too deep a probing depths, they can't brush and floss that. They can't keep that clean adequately at home. And that bacteria is just going to keep proliferating in the gum tissue, and that infection is going to persist unless it is addressed, typically with surgery, to be able to get some sort of pocket reduction. Um, that can be done either regeneratively with regenerating the area, the bone, depending on the case, or with resective type surgery where we're actually reducing the probing depths because we're smoothing and contouring the bone. We're removing excessive tissue, inflamed, diseased tissue. So there's a lot of different treatment modalities that I can use as a periodontist to then get these patients stabilized to then put them back into the hygiene with hygienists to maintain them long term. And that's kind of like the differences between the scope of a hygienist versus my scope as a periodontist is I'm seeing those more aggressive cases that I'm having to do more aggressive treatment on than just the deep scaling and root planing non-surgical treatment is what we call it, which we do that too, but is we always start with that no matter what the patient where they are, is we always start with that first to reduce bacterial load, decrease inflammation, and then that's going to give us a better surgical outcome in the end after that. So it's a good foundation to go from the hygienist starting with their SRPs or non-surgical treatment and then saying, hey, we're not seeing the progression that we should with the healing. And now we're referring to perio, and we're doing some different treatment to be able to maintain this patient long term and stabilize the dentition. Because that's most patients' goals. They're like, I just want to keep my teeth. Like, I don't want to take out any more teeth. And I'm like, okay, well, then we got to brush, we got to floss.
And I think a lot of patients, like the public's, has a big misconception that cavities are how you lose your teeth.
Yes, yes, yes. Valid point.
And so I think getting people to understand that, yes, you can lose your teeth from cavities, but you can lose perfectly healthy teeth because your periodontium is completely shot.
Yep. There's no bone. Like you said, if there's no foundation, then The teeth they're loose. We can't save that. And I think, one of our pros residents, she made a really good point to a patient one time where she's like, "I'm building the house." When she was doing it was like a full mouth rehab case. And she said, "I'm building the house. She's building the foundation. I can't build a steady house if we don't have a strong foundation." And I was like, "Oh, that's such a good analogy to use with patients. Like, I am saving your foundation because right now your foundation is cracked and rotting and we need to fix it. We need to stabilize it." I thought that was
Yeah,
a good analogy,
that is a good analogy, especially for prosthodontists.
right?
They are building the house.
They are building the house. Very pretty house.
Mhm. It's a very expensive house.
It costs a house. It's basically the cost of some houses.
Mhm. It is crazy, but I mean, it is
It's a lot of work.
the stuff that prosthodontists do, nobody else can do the stuff that they do.
Pros is like a whole nother animal. They know everything to do with restorative. Every angle, every detail, the bite, how the muscles align, the materials. They build their own crowns. They layer porcelain. The pros residents literally have blankets and pillows in their resident room.
So they can just lay down and
No, they will
they
spend the night
sleep there.
there. They will literally sleep in the resident room as they have dentures, like, processing. They live in the lab. This is why I did not go to pros. This is why I said, "Hell no." I love my prosthodontists, and we work very closely with them, especially with big all-in-X cases and implant cases. That takes a certain special beast that I just do not have the mental capacity to do. I need my bed,
Yeah.
man. I'm not sleeping in the resident room. That ain't happening.
Chewing, speaking, oral function, impact on aesthetics, because everybody cares about aesthetics.
Everyone loves aesthetics.
Because that's why you have so many people that have unchecked perio and don't know, and their only question that they ask of you is about bleaching because they don't know what's wrong and why. A lot of times they're seeing calculus and it's stained.
And they think it's their tooth. And
Mhm.
then you remove it and they're like, "You just took off half my tooth." I'm like, "Nah, I just took off the calculus and the bacteria that was around
Mhm.
your tooth." And
Yeah.
now they have black triangles and people freaked out because of black triangles.
You get so many questions in your lives about black triangles.
I do. Black triangles is one of like the number one aesthetic concerns, I think, for people
Mhm.
because you can see it and they
Yeah.
don't like it, 'cause especially if it's
Yeah.
in the front. And they're like, "Well, how do you fix it?" And I'm like, really the only way to fix it is restoratively. I can't regrow papilla magically. Unfortunately, it doesn't work that way. There's a paper by Tarnow that talks about the papilla height being correlated to the contact point of the teeth and the crest of the bone. And if you are under 5 millimeters from that crest to the contact point, you're going to get 100% papilla fill. Over 5 millimeters, about 6 millimeters, it drops to about 70% papilla fill. Over 7 millimeters, your chances of getting papilla fill is like 50 to 40%. So it drops like maybe even 30%. It drops drastically as that distance from the bone to the contact point of the teeth increases. And that's why when we see bone loss in periodontal disease patients, that contact point to bone, it increases. So what happens to the gingiva? It goes with it. That's why
Just
we see
goes
the
with it.
triangles. Yeah.
A lot of times too, and the way it was taught in hygiene school is usually that crustal height of the bone that's interproximal is the first thing to go.
Hmm.
Especially like on x-rays, the first thing that I'll ever notice on someone is instead of you having the really good ridge interproximal, it's like blunted. It's like a plateau, and then it'll start to dip and then it just keeps going. And aesthetically, even if not for health, like you say, and I've told so many patients where the bone goes, the gum goes, and vice versa. Because if you have abrasion where you completely remove gum tissue if you're using like a hard bristle brush and you're like going to town. Where the gum goes, the bone goes, and where the bone goes, the gum goes.
Very true. Very true. Like if you got recession, obviously the soft tissue's receding, but so is the bone underneath it. Like we're now creating a dehiscence around these teeth because of the aggressive brushing habits. That can be for another episode. Don't brush with a hard bristle toothbrush, people. Soft bristles only.
I always told people a hard bristle brush is for cleaning grout.
I'm gonna use that. That's good.
Like that's for cleaning your grout. That is not for your mouth.
Not for your mouth. And the dental companies who are making these brushes, I'm like, obviously this was not made by somebody in the dental field because they would never make
Mhm.
something like this. Like the
Yeah.
Oral-B floss action, you know which ones I'm talking about? They have like crisscrossing, they're
That's
like
action.
little plastic things inside the bristles. And I'm like,
Mhm.
that is so aggressive on your gum tissue.
Yeah.
Like, do
But then
not
again, like those companies too tend to come out with I feel like a lot of controversial stuff because like when charcoal toothpaste got big
yes.
and the big brands then came out with charcoal toothpaste and I'm like, why?
The next one's
Why
gonna
would
be
you do
Maxi
this?
Appetite. They're following the trends. They
They
will.
will.
I'm sure they're already working on it.
Probably. They're in the lab right now.
Probably. Probably. They got people working on it hardcore. It's
I'll
expensive.
say, like you said, chewing, speaking, function, without teeth. And some people, you lose one tooth and you notice a difference chewing, especially first molars. I feel like
Oh, yeah.
whenever you lose a first molar, you have a big problem. But then speaking wise, the first teeth that I always see become mobile are anteriors.
Lower anteriors.
And they're the shortest, skinniest roots. They have the least amount of bone. and
And they're hosed.
and you think like aesthetic wise, you can see that if you lose a lower anterior. And then chewing, not necessarily chewing function, but like the function of your incisors are to like pierce food for your initial. So then you're going to be shifting where you're biting at when you are initially eating certain things, impacting as far as being able to eat aesthetic wise. Speech, I feel like your upper anteriors really affect that. Like
Yeah.
where you put your tongue.
I have a lisp when I take my flipper out.
Yeah, I guess. Yeah. And
It's
that's what I'm
bad
like,
too when I say S's. It's like because
uh-huh.
there's nothing there for my tongue to or like
Yeah.
TH. Yeah.
Yeah. And so like maxillary anteriors really affect your speech and anteriors just always are like the first thing to go. I mean, they really are. And 9 times out of 10, and like even with your case, like doing anterior implants is very tricky with actually the placement, the function, and doing that on someone who already lost teeth from perio is
Almost impossible.
very tricky. And the reality of it lasting their lifetime is really low. So, you look at all of the things like because when I see a perio patient and they sit down in my chair and I'm talking to them like you're stage 3 grade C, stage 4 grade C, whatever, and I'm looking at long term. I'm looking at the long term because I'm like, you realize if we don't do something, even if we do something and even if it works for now, just the likelihood of some of these teeth staying forever can be really low. And then you have to look at how do you want to replace it? What do you want to replace it with? Because if you want implants and we're looking at how much bone you have there, and then we look at it from the hygiene aspect of you got to stage 4 perio, how well will implant hold up to this
No, agree.
hygiene wise?
Yeah,
Yeah.
I
And
agree.
so I'm like, it's really difficult to manage. It's those the cases that I see a lot, it just seems complex long term. Like the long term prognosis is like, yeah, we can do SRP and we can get this off of there, but the actual outcome after is unsteady of what we actually know, especially, if you have class 3 mobility.
There's no way.
Yeah. So you look at those things and think of function, and I know patients think of aesthetics, but I have friends who are like speech pathologists, and speech really intersects dentistry as far as, like you said, like people having a lisp, things like that. I have had a lot of patients before who are speakers in one way or another. And if they lose a tooth, they're like, I have to have like immediate something because they're a speaker. And there's then the functionality of the teeth, eating, there's just so much that goes into each individual tooth beyond what anyone could ever imagine.
Percent. And then I I mean, I think it's a big thing too for like as like you said, aesthetics in the lower anteriors. And the only way to really fix it is to do those big like full mouth rehabs to make the teeth look longer. You're doing a lot of restorative, which a lot of people don't have the finances to do that kind of thing. Those big full mouth rehab cases, they can cost like upwards of $60,000. And that's like on the cheaper end. So
Yeah.
it's like not cheap. Um, I think people I think making sure that you're setting expectations for patients off the bat, particularly when it comes to periodontal disease treatment, is because when we treat the periodontal disease, we're going to get a reduction in inflammation. We're gonna get rid of the calculus, like we were saying earlier, changing the shape of the teeth of what they're really used to because it's not their actual shape of their teeth. And with that reduction in inflammation and edema in the tissue, we're going to see a reduction of the tissue itself with recession. That's how we get pocket eradication. And it's going to change the aesthetics, particularly of those lower front anteriors and maxillary anteriors too. But we see it a lot in the lower first. It's and then it's all about the aesthetics for the patient, and it's like but we're also trying to save the teeth, but they're more worried about the aesthetics than the actual disease that they have. So it's and I'm sure you see that too, where they're like, "Well, I just wanted to look good." And I'm like, "Well, you're not gonna have teeth to look good if we don't do this." Like,
Yeah.
I don't know what you want me to tell you. We gotta treat the disease and then we can worry about aesthetics later. But you have to inform the patients before we do any of these, like even SRPs. Like you need to tell, hey, you're gonna get recession, and set that expectation from the start, so that way it's not a surprise, and the patient comes back and freaks out because that happens. And that happens a lot, and I think there's a lot of providers that just need to have that conversation with the patient prior to starting.
My patients probably get sick of me talking because when I treatment plan SRP, we have like a 45-minute conversation at least,
Yeah, for sure. You need to.
like pulling out the graphs and the charts and like,
Yes.
here's your x rays, here's your perio chart. This is like everything. And then when we do SRP, I'm like, this is what SRP is. And we're going to numb you. And like, I mean, I talk their ears off.
Well, that's good. I mean, patient education goes into so much because it goes back to patient management at home and home care. If they actually understand the disease and they understand what is going on in their mouth, they're more likely to actually take care of it at home versus not giving them all the information. They don't know what's going on. They don't understand the like how bad it is. They don't understand like how this can progress to other systemic problems. It's like you have to really have that conversation and make them aware of like you can have other issues that aren't just in your mouth.
Right. Yep. Because your mouth's not Vegas.
Your mouth is not Vegas. What happens there does not stay there. It needs to be on a t-shirt or a sticker too.
I think I have that on the list,
Your
actually.
mouth is not Vegas.
So, how does gum disease start?
Bacteria.
We got this real fun thing in dentistry called strep mutans and P. jalis,
So, yeah.
actinomyo
Actinomyces.
AA
AA. Yeah, I call it AA. Like
AA.
the longest word ever.
It really is. So we have P. gingivalis is like the real big
Pigeon
inflammatory, very inflammatory.
P. gingival P. gingivalis, T. denticola, and T. forsythia are your red complex bacteria. So when periodontal disease happens, you get a shift from your normal healthy microbes to the bad microbes of those more detrimental bacteria. So it's a dysbiosis of the microbiome in your mouth because of the plaque. So the bacteria that's left in the mouth overgrows and becomes more proliferative than the good bacteria. So that's how we get that shift in the microbiome from good to bad bacteria. And that bad bacteria thrives in an anaerobic environment where there's no oxygen. They actually recruit other bad bacteria. Those start to proliferate even more. And there's fusiform bacteria in particular actually acts like concrete and will literally they'll stick to it and it will like grab all the bad bacteria so that you can't remove it. Um, and then you get spirochetes that are like a coil type bacteria.
Disgusting.
It literally looks like a coil. Yeah, it looks like a coil. And they will burrow into the tissue. And I think this is something that people don't understand when it comes to periodontal disease is it's not in the bone, it's in the tissue. It's in the pockets, but all that causing that inflammation that is now resorbing the bone because your body is having this chronic inflammation and it's like trying to run away from it basically. But that bacteria is literally in the tissue. We can't just brush it. Even like I can't scale it, but this is where like ENAP or like Yuckna's ENAP and nucleation of the sulcus or like LANAP is so popular because you're removing that diseased epithelium in the sulcus where a lot of those pathogens are located. Like periodontal disease is so much more complex. That's why it's multifactorial too. So it's not just the dysbiosis that is like the number one cause, but you have some sort of genetic susceptibility to this bacteria that then causes excessive inflammation. But then you can have risk factors like obesity, smoking, diabetes, uncontrolled diabetes that can exacerbate and cause periodontal disease destruction even further than just the bacteria alone. So it's why we call it's a multifactorial disease because there's so much that goes. We really can't pinpoint one specific thing besides the bacteria that causes periodontal disease, but there's so much that plays a role in that because some people have that bacteria and they have plaque, but they never get periodontal disease. So it's like that
Mhm.
genetic susceptibility to periodontal disease plays a huge role in it too. Because then we have other cases who they look like they're brushing and flossing, but they have a very aggressive form of periodontal disease. So it's every case is different and no case is the same, which makes treating periodontal disease extremely difficult and why I literally am going to school for 3 additional years to figure out how to do it because it's not easy.
And I tell patients too, like, you're not just naturally born with all of that bacteria in your mouth. Like, a lot of them, you pick it up. And so I see a lot of patients, or like out in just the world, I see people, like, especially with kids, it's like if their kid's pacifier hits the floor, they'll like take it, stick it in their own mouth to like quote unquote clean it, and then stick it right back in that child's mouth. And I'm like, you just put a whole lot of stuff in their mouth. Like,
They'll survive, build the immune system.
but I'm like, a lot of that stuff, like, it is introduced over time in so many different ways that
Mhm.
people don't think about. I'm like, you get it as a baby with things like that, or, children just breed so much bacteria, daycares. So I'm like, they over time, you just pick all the different things up, but you do have to be, like you say, you have to be susceptible or be a good host for it, be weakened to it. And I tell patients so much. They're like, why does this happen? And I'm like, well, your gums right now are a really toxic environment. And nobody wants to stay in a toxic environment. So your bone leaves.
That's a good one. I like that.
Oh, like your bone has just been sitting in this, waiting for it to change, and it's not changing, and so your bone just leaves. It's over it.
Okay, okay. Wow. I like that. I like that a lot. Yeah, your bone is just like, "Bye."
Yeah.
And it does fast too. Aggressive cases, that bone will be gone, like gone, gone. Most of the time, I can't get it back unless it's a very specific defect where I can graft it to get it back. Yeah, there's no going back. And a lot of people are like, "Well, can I bone graft like horizontal bone loss?" So you like the difference between horizontal and vertical bone loss, right? And like, "Can I graft it?" And I'm like, "Unfortunately, no, I can't. It doesn't work that way. I can't graft just on top of your ridge. It doesn't stay. There's no cells to be able to stay there."
One of my doctors used to would always talk about walls. He would say, like, he'd be like, we, and he would go on a whole like thing about the walls, but he'd be like, you have to have walls. You can be missing one wall, but if you're missing all the walls, we can't put anything.
He's right, we call them wall defects, so it's like you can have a two-wall defect, a three-wall
Yeah.
defect, a one-wall defect, and the type of the defect this is what I did that big presentation on actually last week, is the types of the defect, the morphology really is dependent the prognosis is dependent on that morphology, so, like, you have
Okay.
a worse prognosis when you have fewer walls because you don't have the same blood supply and the viable bone cells to be able to turn over the graft that we place. And so it's you're not going to have as good an outcome when you have like two walls versus a three walled or a four wall defect. You know, four wall defects are best because you literally just have a crater and you graft it and
Yeah.
it basically a socket extraction socket's a four wall
Yeah.
defect. Easy
Yeah.
socket preservation, super easy. It heals great. Bones retained. We're happy. But all of a sudden we need to do a guided tissue regeneration GTR on a vertical defect with two walls, and I'm like, this is a 60-70% chance that it works. Probably less, and we'll get some recession, and it's not gonna get full bone fill, but you know what? It doesn't hurt to try. So,
Yeah.
we try. It's what we do.
Whenever, as soon as I would hear the word wall come out, I was like, we're going to be in this for a minute.
Just talk about
Yeah. So we're gonna be talking about walls for a while, and then usually, like, a patient would look at me after and be like, "What just happened? What are we doing? What is the treatment here?"
I don't care what a wall like, what kind of
Yeah.
defect my walls are. I don't
Yeah.
care. Like,
As soon as the word wall started, I'm like, "Oh, here we go. Here we go.
one of those attendings. I've had
We
those.
gotta get through the whole house now."
We got the foundation, we got the walls, we got the house.
Here we go.
Got a lot of house analogies in perio.
There really is. And Prost, it's the we got everything between all the specialties. We're building a whole community out here.
So what is endo? That they the plumbers? They're doing the lines? Or the electricians?
Gina's gonna see this.
"Gina, don't kill me, I'm sorry." I mean, it's
See,
valid.
Hannah said endo are the plumbers. You know what I mean? You're not wrong.
Working internally, right? They're making sure everything's cleaned and flushed out.
Trying to think of like ortho, what ortho is.
Ortho's like the Chip and Joanna Gaines. They make it they
Ortho's the
benefit.
interior designer.
They're the interior designer. 100%.
Oh, that's so funny. Perio's the foundation. Prost is the house. What
It's
else we got? What's OMFS?
the demolition team.
The demolition. I literally was thinking like knocking out walls.
Yeah, they're the demolition team.
Peds?
Here, what's peds? Like, they're the gardeners making a like, they're doing all the planting. It's like the little baby plants, so
Yeah,
they grow
they're
nice
d
and big.
the
They're doing the
what are those
landscaping.
people? Yeah, landscaping. I was like, what are those people called?
The landscapers. They put in all the baby
Landscapers.
plants so they grow nice, big, and healthy.
We have a whole community out here.
You know, we're building beautiful houses together.
Beautiful, beautiful houses.
It's gonna
Perio's like laying concrete and then hygiene's like smoothing it, you know?
with your file. I love yeah, yeah. That sounds about right.
I explained to patients, I'm like, gingivitis is reversible inflammation where the bone is unaffected. And then perio, we can reverse the inflammation, but we cannot reverse the effect it's had on the bone
Yes.
without surgical, like,
And in some cases, yes,
yeah.
like vertical defects, yeah.
So, mhm. But I'm like, it's in a generalized like audience, just that perio is bone damage
Yes.
and gingivitis is inflammation only.
Yeah, because that's the whole point of periodontal disease diagnosis is the bone loss. If they've had bone loss in the presence of inflammation, then it is periodontal disease. Gingivitis textbook definition is no bone loss. Like we don't have any bone loss. We have inflamed gums. We have bleeding on probing, but we don't have clinical attachment loss. This is where the diagnosis gets very subjective.
And two, with the AAP diagnostics changing,
The
which
World
happened like which had
2017,
happened 2017, but a lot of people really didn't start implementing it until like,
2019, yeah.
yeah, it was a while. And so, and even boards, like I graduated in 2019. The 2017 AAP staging and grading was not on my boards. We
Real
had to learn it, and we had to learn the old way because the old way was on our boards, but the new way is what we were expected to actually use. So, with the changing of the guidelines, it's funny because I hear some people say that it is more subjective now versus before, but I feel like before, because before it was just slight, moderate, severe, localized, generalized. That was like it.
there was, like, no parameters.
No. And
No.
so I'm like, how do people feel like it is more uh, like almost controversial, where I'm like, they have it laid out, every modifiers, everything. And so I like it. I prefer it how it is now.
I do too. I just feel like people take it as, like, a set in stone diagnosis. I think that they don't realize that they still have to use clinical judgment, that it's not always just because they have clinical attachment loss of 4 that it automatically puts them in as a stage 2, but
Right.
there's no probing depth and no bleeding, like, there's no active disease, so they're stable. It's periodontium.
I was taught to only stage and grade on active perio.
Yes.
So if it was someone who comes to me and say they moved from a whole different state, they were just kind of maintained over the years at a general office, but at some point they had bone loss. They may come to me and be perfectly healthy with what they have. And I put in my clinical notes under the perio, like I have a perio section, and I will put reduced periodontium or like stable on reduced periodontium. I was taught to only stage and grade active. So if we're doing active periodontal treatment.
Yeah. No, that's true. Yeah, it's only supposed to be active, but I feel like people see the clinical attachment loss and they automatically assume that they're a perio patient, but I'm like, but, but they might not be because what is the clinical attachment loss from? And I know you've heard me say this a lot in my lives is that people are like, well, what about this? And I'm like, well, do they actually have perio? Like, are they perio susceptible? Because I can look at an x ray and I can tell you pretty quickly, is this patient perio or not? Yeah, they
Right.
might have some deep probing depths. Is it because this filling is shit and it's got like a massive overhang and all of a sudden the body's doing its own crown lengthening? I mean, that's probably what it's from. It's not a perio patient. Or are they taking a calcium channel blocker and they have gingival hyperplasia, which is causing gingival enlargement? And now we have fours, fives, but they have excess tissue. I had a girl on TikTok actually send me her x-rays and show me pictures. And she said they want to do an SRP on me. She's like, I brush, I floss. They said that there's no bleeding, but she sent me the perio chart that she's got some fours and some fives and they want to do an SRP. And I'm looking at her x-rays and I'm like, no, they have this wrong. The bone is literally at the CEJ. She has altered passive eruption with excessive tissue. So she's got deep probing.
Coslet class.
Causally classification 1B. She has excessive gingival tissue with bone and she has altered passive eruption. And I'm like, you don't need an SRP. you need aesthetic crown lengthening. Like this is where being a clinician comes into play and figuring out what the diagnosis and like what the etiology is to get to that diagnosis. And I feel like a lot of people are just thinking this diagnosis is cookie cutter when it's not. There's so
Yeah.
much more that goes into play, especially for this young lady. And I'm like, please do not do an SRP. Go see a
Go
periodontist.
see a periodontist.
I was like, but a lot of people don't understand what altered passive eruption is. They don't understand that that's an
No.
etiology that could cause the deep probing depths with excessive tissue. And I was like, well, do your teeth look small? And she's like, yeah. And I'm like, it's like, bingo, hit the nail on the head. There we go.
Did you actually learn altered passive eruption in dental school, or did you not learn that until perio?
They might have mentioned it, but did I pay attention to it in dental school? No. That's really something I learned, especially the causal classification. I mean, periodontists, we love to classify. We have a
Everything.
classification for everything. We have a
Yeah.
classification for everything. And I definitely did not know causal classification until I became a resident, perio resident, and started looking at that stuff a lot more. They might have mentioned it briefly in dental school, but I've not no, I've not done that.
Because I feel like I've never worked with a dentist that's ever mentioned it.
No, no. A lot of people don't see that and they don't know what to look for. They don't know that the CEJ of the tooth basically being at the level of the bone, that's like the number one indication for altered passive eruption because that CEJ is supposed to be 2-3 millimeters away from the bone because we want to have good soft tissue, connective tissue attachment. And when you have bone in the way, you don't have soft tissue attachment, which can cause excessive probing depths, which people then mistake that for periodontal disease because they're like, oh, I've got fours and fives. I'm like, but why do you have those fours and fives? And I tell that to students all the time. I'm like, why are you seeing this? Why are you diagnosing it this way? And they can't give me an answer. And I'm like, I need you to dig deep and figure out what is causing this before you can actually diagnose it. You need to know why it is the way that it is.
I don't know. I feel like 9 times out of 10, patients that I see have bleeding with probing. And, I'll ask them, are you having, I ask everyone in general, are you having pain anywhere, pain with any teeth, gums, whatever? Most people tell me no, unless they have a toothache. But like anything else, people tell me no. And some of the most severe perio cases I've ever seen, they had no idea what was going on. Not in the slightest. They don't feel it, but a lot of times the only thing they would tell me is I would ask if they have bleeding when they brush, and they would say, "Yeah." And I'm like, "Okay, you didn't have any concerns with that?" And, most of the time they're like, "Well, no, I've always had bleeding. I've always had bleeding." And I think everyone just thinks bleeding gums are normal, and I have a clip of me scaling my own teeth, and I'm kinda like jabbing a Montana Jack a little bit. No bleeding. And so I'm like, having bleeding gums is not normal. If you just bumped into a counter and your arm just started gushing blood, that is not normal. And so I'm like, if we barely touch your gums and you are having moderate severe bleeding, generalized, that is not normal. And with they might see bleeding with brushing, or like I have had patients tell me, "I have bad breath and I've done mouth rinse and it doesn't work." And I'm like, "Yes, because the mouth rinse cannot fix the underlying issue that is going on." And in general, I feel like that's the only two things that people ever notice. Maybe they bleed when they brush, maybe they notice bad breath. And a lot of times they just write it off as I've always bled,
That's what it is.
or I've tried mouth rinse, I've tried an electric brush, or, whatever, and I still have some breath issues. And I'm like, that is where dentistry comes in, is because we can guide you, whether it's perio or not, guide you in the direction of fixing the issue. But also perio is very silent, but very destructive.
The silent killer. Yeah, 100% agree. Yeah, I had a patient come in and he was like, my wife complains that I have bad breath. And I'm like, okay, let's figure out what's going on. Cause that's why he was there. Cause his wife said he had bad breath. I mean, this dude had 10s, 11s, millimeters separation coming out from wisdom teeth that should have been extracted 20 years ago. And I'm like, well, this is why you have infection. And he's like, he was baffled. He was absolutely shook. And I'm like, well, he's like, "Well, could that be what's causing the smell?" And I'm like, "It's 100% what's causing the smell. Like, we gotta extract these teeth. We need to clean up the rest of these teeth." Yeah, did some GTRs on him, but it's like they like you said, he came in because of bad breath. And I was like, "You literally have pus coming up out of the sulcus that you were literally ingesting that." Oh, it's just so, oh my God. Like, unless you've smelled perio, you don't understand the absolute rank, rotting smell of perio.
It's an unfortunate, almost like it's an unfortunate, almost super sixth sense that dental professionals have because nothing else smells like it.
No.
There's not so distinct
Mhm.
that I could just be walking through the grocery store and it just hits you
Yes. It, like,
and you
leaves
know
a
what it
trail.
is.
It, like, leaves a trail of where you've been. You can smell it. Like, it's bad.
And I just like I'm like, it's like it's good and it's bad because like when you're working, you're like, I know what's wrong because it's so distinct. It's bad for like your social life because everywhere you go, you find it.
And you just wanna tell them, "Please go see somebody." Like, what
Yeah.
do you do? Do you tell them, "Hey, I can smell you from here?" Like,
No.
it's like, I feel like I'm
I
doing
don't.
a service.
When it's out in the world, I don't. But like if friends and family that become my patient, I'm probably harder on them than almost anyone cuz I feel like it's usually the opposite. I see a lot of people who are like unfortunately, I mean like underdiagnosing perio happens way too much and it's super prevalent. I almost see that sort of stuff happen more when a provider sees like family or friend cuz it's like they don't want to tell them or like, they don't want to I don't know if it's financial, I don't know, like, what exactly it is, but it seems to be, like, a a common thing there. My friends and family that see me, they have to, like, get into shape real quick. Like, one of one of my best friends, I've known her for so long. Every time she comes to see me, she's like, "I just wanna make you proud. I just wanna make you proud." She's like, "Am I doing good? Please, please tell me I'm doing good."
Or scared of you when they know you.
But I think it's because I'm so honest with them because I'm like, "Look, like, this is something that might not be an issue right now, but if we don't fix this right now, it's gonna be an issue,
Mhm.
and I have to know you for the rest of my life, and I can't sleep at night if I don't tell you about it."
Well, that's how it should be with every patient.
Yeah. Yeah.
Yeah. I mean, that's our job, right? Is to be honest with them and tell them, like,
Yeah.
listen, we need to get this figured out.
Patients that have told me it's not as often. More patients tell me they're glad that I actually explain everything to them because they're like, "Nobody ever explains this stuff." They just go, "You need this, that. We'll reschedule you by." I have had a couple of patients every now and then, though, that are like, "You're really giving me a lot of anxiety. I need you to just stop talking about it." And I'm
Really?
like, "I can't not tell you."
You're like, "I have to. I have to talk to you about it."
And that's where it comes in that, like, I do care too much about my job, and everybody should, but, like, in healthcare, you should, but I do care too much about my job, and I have almost, like, a moral, ethical OCD. Like, everything for me is, like, very by the book of what it is supposed how it's supposed to be done. You can't just not tell people. I don't care what your reason is, and 'cause I know for me, like, if I just didn't tell people that stuff and something happened, I'm going to beat myself up about it for the rest of my life. Like, nobody else would have to beat me up about it because I'll do enough of it.
Well, it's when you feel bad, like, if you miss something or I mean,
Mhm,
nobody's perfect. Like, we can't be 100% all the time. Shit happens. Sometimes we miss something or we procedure doesn't go how we want it to, but, we gotta be honest with the patients
mhm.
and make sure that they are getting the best treatment that they can.
I think it's about your intentions,
For sure. But then
'cause
malpractice doesn't cover bad like, your intention.
Yeah. No, but I mean, if you had the best intentions in mind and you did everything you could, that's one thing versus blatant neglect.
which I've seen lots of blatant neglect. Yikes. Yikes. Well, that's kind of could go and goes into our next episode where we're gonna talk about perio and whole body health and how like that connection is more than just your mouth. Really kind of do like a deep dive into systemic ramifications of periodontal disease and what patients should expect to happen when we actually treat periodontal disease because it goes both ways. Treating periodontal disease can actually help other problems that they have systemically too. So if you guys are hanging out with us and enjoying the podcast, don't forget to hit that like and subscribe. Follow us. We are both on TikTok, Cheyenne RDH, and then Hannah DMD are our TikTok handles. And this is a brand new beginning of the Too Much Plaque to Handle podcast that we are super excited. So if you guys want to come along for the journey, hit that follow and subscribe, and we'll see you at the next one. Bye.